I'm going to talk about two different things, actually. I'm going to start talking about ADT. We really don't have an ADT talk here, so I'm going to just talk about some advances in ADT, if we can pull up my first set of slides. And then I'm going to actually talk about non-metastatic CRPC right before Oliver talks about sequencing therapies. So this has been actually a time of a lot of activity in the setting of ADT. These are my disclosures. And everyone knows this story. You know, I always like to tell people that androgen deprivation is the first targeted therapy. We just didn't really understand the target, but AR is a target, and removing the ligand, testosterone, clearly had profound effects and continues to have profound effects on the reduction of cancer burden in prostate cancer, for which it was Huggins was awarded a Nobel Prize. The milestones in hormone suppression are noted here. Oral therapy with DES and then subsequently LHRH agonists and antagonists have led to a second Nobel Prize. I don't know if you know that the creation of the LHRH peptide led to a Nobel Prize in chemistry because apparently it was very difficult to synthesize. And of course, leuprolide has been around since the mid-80s. In 2008 now, I guess it's quite a while. It's 15 years. We had our first GnRH or LHRH antagonist, Digarelix, and many of us have been using it. Lots of variations on how we use an antagonist. And then the first oral GnRH antagonist, Relugolix, was approved just a couple of years ago. So everyone understands this, but just as a reminder, again, the reason we had an agonist, the agonist never made sense, right? The way that these drugs work is they suppress the pulsatile flow of GnRH from the hypothalamus to the pituitary gland. It's really like a Morse code that leads the pituitary to release FSH and LH, which leads to testosterone production. And it's really the continuous production of LH and FSH actually is what leads to a negative feedback loop and shuts this whole process down. But that's why you get a temporary flare. The better drug was always the idea of an antagonist, where you simply block GnRH signaling at the level of the pituitary, and you don't get that flare. You don't get the proposed testosterone flare. And so, you know, we know that in certain high-risk patients, increased testosterone, even temporarily, is not a good thing. The other issue that I'm going to be focusing most of my talk on today is whether or not there are differences in cardiovascular morbidity between related to ADT itself and maybe between GnRH agonists and antagonists, which is, of course, a topic that has been of great interest to many of us. In fact, you know, we take a lot of these things for granted. I think that because these drugs have been around and were actually tested in pre-randomized trials, we never really quite appreciated how significant cardiovascular morbidity is with androgen deprivation therapies of all kinds. And this is a Medicare cohort. You can see that at least in registry type data, patients who get ADT versus those who don't get ADT, there's a 20% difference in serious cardiovascular morbidity related to ADT. Now, these are the two GnRH antagonists, one injectable and one oral. And we'll be talking a little bit about this. And just for your reference, there's some of these comparisons here. Obviously, the biggest one is oral and one is an injectable. There are some hypersensitivity issues. You may have prolonged QT, so you should be considering baseline EKGs in these patients. I'm going to talk a little bit about the metabolic effects of all ADTs. But this is what led to Digarelix's approval 15 years ago now, and it was Digarelix versus leuprolide in 600 patients who had an indication for ADT. When we all saw this, we saw a couple of interesting things. One is that you didn't see the testosterone flare that you saw with leuprolide with either of these dosing strategies for Digarelix, the loading dose plus the lower dose maintenance dose. And the suppression of testosterone was really equal across all three, and you got to it faster with Digarelix. And this was considered non-inferior. It was approved on a testosterone basis, not on a therapeutic basis. And more recently, in the New England Journal, about almost 3 years ago now, Neil Shore presented the HERO trial, which was a randomized phase 3 study, open label, of Relugolix versus leuprolide. And again, you saw not just a very high response rate with relugolix, but sustained castration over many weeks. And in terms of the speed with which testosterone was suppressed, relugolix was much faster, as shown. So the side effects are as we would have expected. It's not clear that there were any significant differences in the side effects in terms of common ADT side effects like fatigue or some higher rates of diarrhea, higher rates of arthralgias, but really not statistically significant. And in fact, there was this intriguing lower rate with relugolix of fatal adverse events and perhaps cardiovascular events. So we know the common side effects of the ADT, which include hot flashes, osteoporosis, fatigue. These are very common. We've learned over the past decade and a half to be more aware of this, to get baseline density tests to try to treat and acknowledge hot flashes. There's not a lot of great treatments for fatigue. My most common recommendation to patients, if there's no contraindication, is coffee or other sources of caffeine. Just the reason I recommend so much coffee to my patients is when I was a fellow in Boston many years ago, somebody had created a company. I guess this is before 6 Hour Energy. They were trying to sell to oncologists caffeine pills for fatigue. And I thought, I was driving by 10 Dunkin' Donuts on my way to work, and I thought, everyone drinks coffee. All the doctors drink Diet Coke. Why not suggest to my patients increase caffeine? But as you know, there are not a lot of very good options for this from a medical treatment point of view. And I'll talk about some of these other areas, including the cardiovascular and thromboembolic risks. And I think the most important piece here is that, as men have gotten healthier and live longer, and as cardiologists have started to outpace us in keeping men alive, we have to recognize and actually balance the risks of treatment with ADT versus the side effects, including issues, as I mentioned, around cardiovascular risk, bone health. I think exercise and healthy lifestyle changes really are an important piece of this, really bringing in other categories of support like nutritionists and encouraging exercise. And then we'll talk a little bit about what other interventions we could consider. Metabolic syndrome related to ADT is a very interesting phenomenon, both pathophysiologically. I was talking to somebody about whether some of these new anti-obesity drugs can transform cancer care. Everyone a few years ago was very interested in whether metformin could be a cancer drug. And, the bottom line is metformin's cheap and quite safe, but it is not a cancer drug, right? I think we can all agree that if it has long-term benefits in terms of modifying cancer risk, they're modest and not easy to see. And they're certainly not an anti-cancer treatment in somebody with advanced cancer like prostate cancer. But on the other hand, there's a lot of serious metabolic consequences of ADT. These patients gain weight, they have dyslipidemia, they lose muscle mass, they develop sarcopenia, they develop insulin resistance, all of which ironically might increase not only cardiovascular risk, but really we have a poor understanding of what it really does to cancer risk. Like, for example, we know that diabetes may be associated with increased progression of prostate cancer, and yet we may be causing more diabetes. So how do we reconcile both the benefit of the treatment versus the increased morbidity of what we're actually doing with the treatments that we have? So there are strategies, as I mentioned. Fall risk is an important one. Structured exercise programs. We probably really under-rep this in our practices. Many of us don't have resources. Certainly in small offices, you don't have resources. But I've found that patients, when they're told by their doctors to go find a trainer or to exercise or go walk around the block, that they actually listen to us and that we should be really focusing a little bit more on it. So I'm going to just skip this. So, just a couple of points for how to manage men on ADT. One that really has changed over the last decade for me, because we have treatments for this, not just calcium and vitamin D, but rank ligand inhibitors and bisphosphonates, is really to assess bone health history. I don't do the FRAX score anymore. I simply ask them a little bit about their history, and I just order a bone density test. It's important to do. You don't have to do it on the first day when you're about to start ADT. Just put it into your checklist so that you know what their baseline bone density is. In the United States, Medicare will cover a DEXA scan every 2 years. And And the main thing is just remembering to do it, because some patients don't lose bone density at all. And some patients really have osteoporotic fractures, and those can be very painful. All of the patients should be on calcium and vitamin D. And when my patients are on long-term ADT and they have osteopenia, I do strongly consider adding a bisphosphonate in that setting, or denosumab on an every 6-month schedule, just because I know their bone density will continue to get worse. So this is the interesting feedback loop I was talking about earlier, about how the treatment we give for prostate cancer may in fact have this additional risk, like really a two-way risk towards cardiovascular disease. So we treat patients with prostate cancer with drugs like ADT that increase cardiometabolic syndrome, which may lead to worse cardiovascular disease. And yet we know that these drugs are life prolonging. So how do we balance this? And do we understand, for example, what the genetic risks are? We know cardiovascular risk, just like prostate cancer risk, is not uniform across the board, right? That there are men who might have underlying cardiovascular risk or genetic risk that we don't actually understand, but where ADT may actually increase their long-term morbidity, and actually it may kill them. So, like in the, like many of the studies that we're talking about, we need 5, 10, 15 years to see the benefit of some of our interventions. And yet we may be doing worse harm if we don't have clear evidence of the benefit of, let's say, adding long-term ADT. So these are some of the mechanisms that I mentioned. And in particular, I would really focus on the ones where we can actually intervene. Like we can definitely intervene if somebody has insulin resistance or diabetes. We can certainly intervene with dyslipidemia. We can try to improve fatigue. We can try, there are now patients of mine, this depression issue is, I think, also not well understood. My favorite drug now is venlafaxine, because it turns out a lot of my patients are depressed but don't tell us that they're depressed. And if they have hot flashes, it's a 2-for-1 deal. So, we as cancer doctors sometimes under-focus on this, and it's really something that is causing suffering in their patients. So to focus back on cardiovascular risk, this has been controversial for some time, as many of you know. First of all, as I mentioned, it can actually increase some of the risk factors known for cardiovascular disease. The reports have been inconsistent. There are some studies that suggest that ADT does increase cardiovascular death, and some that don't, and differences between different forms of ADT, orchiectomy versus LHRH agonists, and now LHRH antagonists. I know this is a little bit hard to read, but I just want to point out that there have been a series of studies, whether they're meta-analyses or retrospective analyses, all suggested that there may be fewer cardiovascular events, or CVEs, with LHRH antagonists or GnRH antagonists. And you can see that there was a series of them that actually suggested that antagonists had lower cardiovascular events. And when these retrospective studies started coming out 4 or 5 years ago, 10 years ago, I know that I started changing my practice. If somebody came in with significant cardiovascular disease or risk factors for it, I started thinking about using a GnRH antagonist with the possibility that it might prevent a cardiovascular issue. But I will say the most important thing that I learned is we should make sure their cardiovascular disease is managed. I mean, this to me is part of the confusion here, is that probably the greatest risk, if you go back to Anthony D'Amico's early randomized trials of radiation therapy versus plus or minus 6 months of ADT, some of you may know that Anthony did that study in Fall River in Massachusetts, with a working class town where a lot of patients were smokers and had like underdiagnosed or undiagnosed cardiovascular disease. And he saw a very high risk of cardiovascular events in the ADT arm. And it just shows you that sometimes, when I would look at his data, and Anthony was convinced that there was a cardiovascular issue, that was very different from the patients we were seeing in Boston, where they had 3 cardiologists already, And it does get to the issue of why, if it's underdiagnosed or undertreated, that's where you might be seeing these increased cardiovascular events. So let me just go right to the randomized trial. Of course, this was the HERO trial. This is the Relugolix trial. And this was a secondary endpoint. It was really the AE slide. And what you see here is the chance of a major adverse cardiovascular event, or MACE, was 5.6% with leuprolide and 2.8% with relugolix, a 54% reduction. So this also correlated with what we were seeing with dagarelix a decade earlier. So there was a suggestion of a major reduction with LHRH antagonists compared to agonists. And again, if you look at the hazard ratio the odds ratio for a cardiovascular event, it clearly looked like it was better, especially in patients with a prior history of MACE. So this gets to my story about Fall River. If a patient has known serious cardiovascular events, that may be where the greatest benefit of a GnRH antagonist might be. Now, so the company went ahead and did a randomized trial with a primary endpoint of MACE called PRONOUNCE. And we were waiting for this result. And in fact, there was no difference at 1 year in major adverse cardiovascular events with relugolix versus leuprolide. So why is this? Well, I don't have the time or the knowledge to understand why this prospective randomized trial was actually negative. But it may get to some of those cardiovascular issues that I just mentioned. Like patients who go on a trial with a primary endpoint looking at cardiovascular disease may not be the same as patients treated on a clinical trial of prostate cancer where nobody's thinking about the cardiovascular risks. But that said, at least in this study, there was no major difference. And that's probably the best cardiovascular prospective study done on this subject with GnRH agonists versus antagonists. The other thing, of course, in advanced disease, in CRPC and metastatic hormone-sensitive disease, the areas that Alan just reviewed, we're giving tons of these new AR-targeted therapies, ARATs, RCs, ARTs. You'll see all these different names, so apologize for all of our acronyms. We should, as a field, always get one acronym and agree to do it, but we never do. And this was one paper that recently, about a year ago, that looked at abiraterone versus enzalutamide in terms of cardiovascular hospitalizations. And you can see that on this blue line, you have cardiovascular hospitalizations with abiraterone, which seems to be higher than with enzalutamide. Now, there are these oncocardiologists now at major medical centers who are studying this. It's very hard to study prospectively. A lot of it is comparative studies, but suggests that, I think we all recognize that abiraterone, maybe less, that's not really the prednisone, although prednisone causes some fluid retention, that abiraterone may cause more hypertension, may cause more cardiovascular risk. Much of these hospitalizations were actually related to congestive heart failure. But I think this is an open question about whether there are some AR-targeted therapies that are clearly worse or better than others in terms of cardiovascular risk. But I do tend to avoid abiraterone if somebody has major cardiovascular risk factors. So again, some of the things we talked about, I have a handful of patients who have just uncontrolled hypertension, sometimes African-American patients who come in and I have they're already on 2 or 3 drugs, and then I put them on abiraterone and I can't control their blood pressure. And I will often switch them to another AR-targeted therapy. Okay, so the other piece I mentioned was none of us want to be caught up in managing, their blood pressure or their cardiovascular issues alone. You really want to bring in their primary care doctor. You want to bring in their cardiologist. If you haven't one, an oncocardiologist. I think some of these other areas that I mentioned earlier, I don't have time to talk about cognitive issues, but that's an interesting area in and of itself that we might bring up during the panel. And so what are the key issues selecting between one? It is interesting. My practice has started to change. I've never had an LHRH agonist or antagonist injected in me. So I really don't understand what the differences are from a quality of life perspective, but I've used them all. The only ones I really haven't used are the permanent implants that surgeons will implant. But the general issue is, I think mode of administration does matter. I think, unfortunately, dagarelix is especially the loading dose is quite painful for many patients. It's also monthly, and coming to my office in Manhattan every month is not necessarily very easy. I think the efficacy issue, the most important part of that is whether you think that rapid drop in testosterone matters. And I think it probably does in very high-risk individuals. I don't like to use bicalutamide anymore. I don't like to see a testosterone flare if I'm really concerned about the patient. So I think antagonists clearly have an advantage there. I think the issue about the oral versus sub-Q or IM injections is very important. You have to ask your patient. I mean, and as I'm using more oral relugolics, I am finding that patients actually prefer it, but it's more complicated because the copay issues come up with oral therapies, as everyone knows. And whether there's a difference in some of these metabolic risk factors, I think is, to me, a little still unclear. But if there's an advantage, it probably goes towards antagonists in terms of cardiovascular risk. I'm not going to go over the NCCN guidelines, but it basically talks about all the things that I just mentioned. And again, I think, I know probably this is true for some of the other oncologists. I see my patients and I draw chemistries on them and I see their glucose is running at 120. And my eyes kind of glaze over. I don't even sometimes notice it. And then 3 times later, now the patient sees it and he says, "What's wrong with my blood sugar?" I say, "Yeah, you know what? That's true." And so I'm adding more hemoglobin A1Cs and then sending them back to their primary doctor, because we probably shouldn't be ignoring this and probably should be more aggressive. So these are my take-home messages here. ADT is associated with increased cardiovascular risk. I think that's true. I think that GnRH antagonists may have fewer cardiovascular events. It remains controversial, but I think it is something that has changed my practice with the availability of so many choices. I do think abiraterone is probably more likely to induce cardiovascular events than enzalutamide in patients with high-risk features. And just address and understand these factors before you use these drugs.